Good afternoon and good morning to people. My name's Margaret Hallard from the Burnet Institute. My co-chair is Professor Sayed Hamid. Welcome today. Being based in Australia, I'd like to welcome and make an acknowledgement to country, acknowledge Aboriginal and Torres Strait Islanders, the original owners of the land in which we meet, and pay my respects to elders past, present and emerging. I'm on Wurundjeri land where I am at the moment in Melbourne, Victoria. We've got a really excellent session today on hepatitis elimination in the time of COVID-19. I want to thank CEVHAP and WHO, Wipro for helping in the organisation, playing a huge role in organising of this. But before we get going, I'm going to hand over to my co-chair, Saeed, to really acknowledge two great people who have been put enormous time and energy working in the field of viral hepatitis, who've recently passed away, Professor D.S. Chen and Dr. Nancy Luong, to acknowledge their enormous commitment to the field. So over to you, Saeed.
Thank you, Margaret. Hello, everyone from the Aga Khan University in Karachi, Pakistan. So, as Margaret said, we just need to start on a slightly somber note because we've lost two of our champions, not just from the Asia Pacific region, but actually global champions of elimination. The first one was our very own D.S. Chen, and I say very own because he was the founding co-director along with Stephen Locarnini from Australia of CEVHAP. He died on the 24th of June 2020, and I think his loss will be felt all over, and especially in the group that is CEVHAP right now. People who know Professor Chen would immediately associate him with all the work, all the great work on hepatitis B that went on in Taiwan, which included the hepatitis B vaccination, the natural history of hepatitis B, so many seminal articles that came from his group, to the extent that they could show how significantly and tremendously they could drop down the prevalence of hepatitis B in children, particularly in Taiwan, and the decline in liver cancer. And this led to the Hepatitis Control Committee that was formed in Taiwan, and the rest, as they say, is history. The second person that we are acknowledging today was Dr. Nancy Luong from Hong Kong, from the Chinese University of Hong Kong, where she worked for many, many years as a physician and as a scientist. She became better known during her later part of life as the founding chairperson of CEVHAP, which was a civil society organization that she ran with a lot of success for many, many years. And for those of us who were starting out in this field at that time, she was really a beacon for us in the area of hepatitis elimination. The two commonalities between those two people, they were superstar physicians, scientists, academics, and in their later years, they turned their attention to public health and to the cause of elimination of hepatitis B and C. So as CEVHAP, as a group of people in Asia Pacific, hopefully we need to live up to their expectations. Thank you. And with those words, I'll hand over to Margaret to get the first session going. Margaret. Margaret, you're muted.
Thanks, Saeed. Beautifully put. I appreciate that. They were legends in the field. Nanki, can we have the next slide, please? Okay, so the first session today, we've got three fabulous speakers. Professor Rosmati Mohammed, who's going to be speaking first, followed by Joe Doyle and then Jitan Karakpan. It's looking at access to hepatitis C care, and again, in the context of some of the challenges around COVID. So Rose, over to you to speak first. Thank you very much.
Okay, great, thank you. Just share my screen. Great. So this is my task this afternoon, to looking at the impact of COVID-19 on screening, cancer treatment, and clinical trials. So you see, I had this first slide to really look at the COVID-19 pandemic impact on hepatitis services from this survey. So this WHO survey was undertaken, sorry, let me just get this, it was undertaken between April and June this year to assess the disruption of hepatitis services in HIV as well and STI. So just specific to hepatitis services, you can see from the left that a number of countries reported disruption across the region, with the highest number reported from the Western Pacific region. And the main reasons cited for these disruption includes the diversion of health systems, the lack of access to health facilities during movement restrictions, as well as the stockout of drugs. So the number of countries that responded are shown here at the bottom right. So the data was collected for prevention, testing, and treatment services, and I'll just focus on the hepatitis services. So you can see here that 10 countries reported disruption in hepatitis B testing, and 6 countries faced disruption in hepatitis C treatment initiation. So with regards to the prevention program, 5 countries each reported disruptions in needle and syringe exchange for people who inject drugs, as well as harm reduction. But you can see the note down at the bottom here that the prevention programs for people who inject drugs were only present in very few selected countries. So what is estimated is that the disruption may be occurring in most countries where there is such a program. So clearly we can see that the key hepatitis services were disrupted, particularly in the high-risk group. So in addition, people living with hepatitis face other challenges as well, such as the continuity of treatment. So let's look what the country responses are in response to this disruption. So here you can see that a number of countries actually adopted this multi-month dispensing, and this is actually 3 to 6 months of dispensing if the current stock levels can allow for this initiative. So for this multi-month dispensing, it was adopted for opioid substitution therapy, for prophylactic medication, as well as for hepatitis B and hepatitis C drugs. And what, on a positive note, the use of this multi-month dispensing and community delivery may actually offer benefits in the long term, because you can actually reduce the staff times needed to run these programs, and at the same time promote the innovation in people-centered service delivery. Now, alarmingly, disruptions in cancer services have also been reported. So nearly 80% of countries that responded in this survey by WHO actually reported.
Rani, I just sent an email, copied you to Mike about RD's speech. RD sent.
I'm sorry? Sorry. So nearly 80% of countries.
Keep going, Rose.
Okay. Nearly 80% of countries that responded in the survey reported that NCD services, including cancer, are disrupted. And you can see that the severity is dependent on the extent of the infection. So the more severe the transmission phase of COVID-19 pandemic, the more the NCD services are disrupted. So the worst case scenario are in red, and you can see here is high for all across the 4 common NCDs, including cancer services. And this disruption has been seen in the spectrum of cancer care, which included the delay in diagnosis, linkage to care and treatment, as well as even halting clinical trials. So with regards to delay in cancer diagnosis, it's not just about the reduce or suspension of the screening programs and diagnostic services, but also patients are a bit more reluctant to actually present themselves to the healthcare services for fear of exposing themselves to the risk of infection. So in addition, the treatment pathways for cancer may also be altered to minimize potential exposure, particularly during surgery or radiation therapy. So the certain aspects of ongoing cancer care have been deprioritized. And this is to enable the healthcare systems to respond to COVID-19 pandemic, but also can result in patients receiving suboptimal or delayed care. So the last thing that I've written here is many clinical trials have been suspended, and this can be an important option that has been reduced for patients, or some patients at least, who might have otherwise participated in clinical trials. So in response to this disruption, some healthcare systems in some countries are reorganizing their cancer services to ensure that these patients continue to receive essential care, at the same time minimizing exposure to the infection. So other approaches used to actually to address the related disruptions are shown here. And you can see that the two highest, or the two most commonly used to overcome disruptions, are the use of telemedicine in purple, as well as the triaging in light green. So really, telemedicine is deployed to not only replace in-person consult, but it can also be used for training and mentorship of non-specialists and nurses. For example, this is to enable the task shifting or the role delegation. And a wonderful example for the use of telemedicine and task shifting is the use of the telementoring of primary care providers in Project ECHO, which refers to the extension for community health outcomes. So triaging is also plays a crucial role, and this is really to identify priorities as well as assess the level of care needs. So then in the next slide, I will show you an example, and this is an example of a simplified guidance for prioritization of care in patients with liver disease, and this is from the EASL-ISNIT guideline. And you can see here that for patients with chronic liver disease, including those with compensated cirrhosis, visits to specialized centers can be postponed. In contrast, patients with decompensated cirrhosis and those with HCC, the care should be maintained according to the guidelines. But really, at the individual level, the management of these patients strongly will depend on the local burden of COVID-19 and also the local guidelines present. So shifting now to looking at the global impact of COVID-19 on clinical trials. So this analysis is from Medidata, which showed that a 65% worldwide average reduction in new patient enrollment in March this year compared to March last year. So among the major players in the market, there was a 43% reduction in the enrollment in Japan, 84% in India, and 67% and 68% respectively in US and China. So this impact of COVID-19 is not uniform across the therapeutic areas. For example, the enrollment studies for oncology was 48% and 47% for infectious disease reduction wise, but for endocrine diseases, there's a larger impact with 80% reduction in enrollment, less in respiratory disease, of only 34% reduction. So what you can actually really see here, it's written here, is that the challenges due to COVID-19 really can lead to difficulties in meeting protocol-specified procedures. But the overall message is this: as much as possible, the clinical trials should continue, but the protocol modifications may be required, and there may be even unavoidable protocol deviations. So in March this year, the US FDA issued a guidance. That was an emergency guidance, which was last amended on July 2nd to address the current challenges to the trial processes. And what's central to the highlighted in the guidance is that patients, the clinical trial participants' safety must be maintained. So there are other ways to look at how these studies can be conducted. And one of these recommendations is using alternative methods to study conduct. And that's looking at, for example, alternative methods for safety assessment. And sponsors are really encouraged to determine whether in-person visits are really necessary to fully assure the safety of trial participants. So others which have been recommended include the use of technology diligence and the trial virtualization assessments and approval management. And again here, telemedicine is discussed in great detail, and the US FDA, although it does not endorse any particular telemedicine best practices, it does equip them with in-person sessions. So this is my last slide to summarize. To date, there's overall reduction in service provision across the health sector, which has impacted hepatitis B and C testing, as well as treatment initiation for chronic hepatitis B and C. So no doubt there is widespread disruption in the spectrum of cancer care, which includes delaying diagnosis, linkage to care and treatment, and even halting clinical trials. Now, the dramatic declines in the new patient enrollment during this pandemic truly indicate that clinical trials are equally vulnerable to the state of public health. So in order to actually really respond to the COVID-19 pandemic, countries will need to rapidly reorganize their healthcare systems to ensure that hepatitis and cancer patients will continue to receive essential care while minimizing exposure to COVID-19. With that, thank you.
Thanks, Rose. In the interest of time, we won't take any questions. I just wanted to say, though, that if people have any questions, if they would like to put them up, they can put them up on the Q&A or the chat session. It's being monitored, so if they've got questions, and we can come to them later. Similarly, I think there's been a question on the chat as to access to the slides. And Jen, I'm assuming that we will be able to, we'll be asking the presenters to provide the slides to CEVHAP, and then CEVHAP will organise to put them up or have them available. We can sort of send further information about that.
Yes.
Sayed, thanks. Sayed, I might hand over to you now to introduce the next two speakers. Thanks.
You're on mute.
Thank you, Margaret. Next speaker is Dr. Joseph Doyle, Deputy Director of the Elimination Program in Burnet Institute. And he's also on the steering committee of the National COVID-19 Clinical Evidence Task Force in Australia. He's going to talk about how to reach vulnerable communities, challenges, and solutions amidst COVID-19 lockdowns. Joe?
Thank you, Syed and Margaret, and to the organisers for inviting me to speak. I hope you can see my slides fine.
Yes.
Great. Well, I have been asked to follow on that fantastic talk, setting the scene from Rose, to try and touch on some of our vulnerable communities and the challenges and solutions we have been using clinically in COVID. Of course, I'm coming from a very Australian perspective, and I'll try to touch on some ideas which I think are shared across the region, but I know that they will be very applied very differently in very different areas depending on health service access. But let me start by commenting on what I think some of the further to what Rosa said, some of the key challenges affecting the vulnerable, more vulnerable people living with hepatitis, particularly hepatitis B and C. We know that there have been reduced access to harm reduction services, including things like opiate agonist therapy, getting harder to get to pharmacies, restrictions on how you actually attend services, even simple things like signing logs in pharmacies to pick up opiate replacement therapy have all posed challenges. We also know that there have been declines by up to about 30% in hepatitis testing from some of our national data in Australia. And I'm sure that's being reflected over the last 3 months in your countries as well. So with hepatitis C testing dropping off because of difficulty accessing hospitals or community-based testing services. Starting treatment has declined in Australia over the last 2 months as well for hepatitis C and probably for hepatitis B because it's been harder to get through community services, through hospital services and through some of the outreach services. partly because these services are focusing on COVID, and partly because a lot of us have been told we're not allowed to leave our comfortable ivory tower hospitals to reach out like we used to because of understandable, I guess, concerns about both our own health and transmission of COVID around the community. And finally, screening services, whether they're screening antenatally or hepatoma surveillance services, we know that a lot of these things are impacted too, just because of the number of medical visits that people are able to get to. There's been some really interesting Australian data, which you can see on the Burnet website, on changes in drug markets and drug use as well, which is particularly important for vulnerable communities. The key message is that most drugs are costing more. Some usage has gone up, in particular alcohol use has gone up. And I guess this is a reflection on being isolated, potentially at least the myth that there's less drug around. Some people are telling me that's not necessarily true, but it's pushing prices up. And that has a big impact on with addictions and people who are already vulnerable and don't have huge resources to be able to afford that. We also know that holistic health has been impacted. So people aren't going to their doctors for routine checkups, let alone hepatitis, which of course is what we're talking about. But that holistic health service has a big impact on psychosocial health. The availability of crisis accommodation has been changed, and the way people can access it locally has changed. Perhaps one thing which we have seen, we've been lucky in the city of Melbourne, is that some people who are experiencing homelessness have actually been provided with accommodation for, you could argue, in some ways, the first time. They've been given hotels to try and recognise the fact that they might have been more vulnerable to COVID. And it's interesting that that happens when there's this sort of pandemic on, but it's not necessarily something which our normal governmental response is doing in relation to vulnerable populations. And lastly, there's a challenge, I think, in technological barriers and disparity in who has access to technology, because one of most health system solutions to this lockdown period has been to change towards telecommunications, whether that's phone, messaging, or telehealth services, but they all rely on someone having very good access to technology to have the high bandwidth telehealth that we need. And even more than that, just being available for health service providers who want to dial someone at 10:55 in the morning and assuming that someone's available. We know that that's not always the reality. Although I wanted to touch on a couple of, at least I think, fortunate or less negative aspects of COVID. We're probably used to vulnerable groups often being more harshly affected by pandemics or viruses, but at the moment it seems on the whole that hepatitis B and hepatitis C is not directly impacted by SARS coronavirus 2. Of course, all the other things we're talking about are showing the other broader society impacts, but the virus itself is not necessarily making someone more vulnerable to COVID. The exception, of course, and I'm sure Saeed would have seen this, very sick people with very end-stage liver disease, if they get COVID, might be worse off. But the vast majority of people living with hepatitis probably don't have any worse course from COVID. And I just pose this as a little footnote to say, I wonder whether some of the treatments that we're seeing out there at the moment may, for hepatitis B or C, whether it's tenofovir or sofosbuvir, are being postulated as potentially modifying the course of COVID. I'm not advocating them, but if anyone says COVID is a bad time to treat, I would say, no, it might not be. Some of these drugs are being trialed as potential disease modifying agents. So that might be one silver lining for some of our community, people living with viral hepatitis. Now, I wanted to touch on some high level ideas on solutions, or what I might even think as opportunities. Firstly, I think this is an opportunity to really focus on patient-centered health. We have often required people who live with hepatitis to come to the doctor or another healthcare provider rather than taking care to them. And maybe this is an opportunity. We're seeing new models of outreach to deal with COVID. We really should be trying to apply that to viral hepatitis. I think we should start to see and open up new testing pathways instead of requiring very heavily regulated institutional-based testing for pathology providing. And this is very much perhaps an Australian comment here, but we have very established pathways for testing, and they are very heavily subsidised, which is a good thing. Potentially, this is now the time where all of the new diagnostics for hepatitis B and C are really scaled up because they are simpler and they don't require all the infrastructure that we've used traditionally for serology and virology for Hep B and C. So getting those testing pathways out into the community could really be critical, especially as COVID may obviously roll on for another year or two in many societies. Task substitution was already touched on. I think this is critical too, because you don't necessarily need to see a doctor for monitoring hepatitis. I don't think you necessarily need to see a doctor to start hepatitis treatment. And so as we move to getting peers, other healthcare providers, and even home-based testing for a whole lot of things. We're all great shopping on Amazon. Why can't we do this and task substitute and have testing at home potentially? There's lots of barriers. There's always been barriers, but we're seeing a lot of other things, these barriers broken down by COVID. Maybe this is some task substitution could happen here for testing and treatment pathways too. And I do think our treatment, we do need to simplify how we treat people instead of insisting on lots of visits. Visits to healthcare services are risky for the providers and the patients at the moment. So if we can simplify things to get treatments down, treatment simplified to one visit to start, it's what we do with lots of other infections. And I wonder whether we need to think of that too. And I also think that we need to use COVID services to look at how we can provide holistic care for vulnerable people. We are starting to provide outreach for COVID, as I touched on, based on hotels in Melbourne, and we should start to think of how we can use that in reverse. Let me just show you this is the only slide I'm going to show you with some local information. This is a picture of a van, which one of our nurses kindly provided me with. There's been a mobile immunisation service started in Melbourne just in the last couple of months, which was focused on actually on hepatitis A, because we've seen an outbreak of amongst people who are injecting drugs in Melbourne. So that was the impetus to think, well, how can we get hepatitis A vaccinations out to people who are experiencing homelessness? And it happened during the COVID pandemic, and it was very patient-centered. So it actually had a pathway of getting people tested for COVID if they needed it. And now we're working on how we can expand this to look at mobile harm reduction, bloodborne virus testing for hepatitis and HIV, and looking at other health and social services that can be provided in this model. And I think that that is one example, just one, of how we might be able to look at new models of care that before COVID came along we wouldn't have thought about, and how we can integrate hepatitis and COVID care together. So I might finish by saying that the last thing to think about as a solution or opportunity is to think about how, instead of trying to collect all of our data on our progress towards elimination based just on hospital-based hepatitis testing, we really need to look at how we can integrate all of the routine access people are having to healthcare. So we can, instead of insisting on it all being sort of separate and quarantined and segmented into hepatitis specific, that might be one last solution to think of how we can engage and monitor our progress towards the elimination targets. Thanks very much, Saeed.
Thank you, Joe. That was a wonderful roundup of these difficult issues. We'll go directly to the next speaker, and I believe we'll have a panel discussion at the end of the session so that we'll take all the questions. So please keep your questions coming in the Q&A box, and we'll get the opportunity from the speakers to answer them. So next up is Jiten. Jiten is from, as everybody knows, from Thailand. And I can't think of a better person who can crash through roadblocks and get to the hepatitis B and C elimination programs with or without COVID. Jiten, please. Is he here?
Yeah, I'm here. Thank you so much, Dr. Said. I'm not being able to start my video. I don't know why. Can you see my slides well?
We can see your slides.
And we can hear you really clearly. And now we can see you as well.
We can see.
Okay, thank you. Thank you very much, Dr. Hamid, and good morning and a good afternoon to all of you here in this webinar. You have heard about the disruptions that are being created because of the current COVID-19 situation in accessing healthcare. You also have heard from Dr. Joel about some of the potential solutions or opportunities that are coming up to address some of this, including newer ideas to better provide healthcare. My talk is going to mainly focus around reinforcing the information that we cannot forget viral hepatitis B or viral hepatitis C. We have made international commitments towards eliminating these viruses as a global community. We have huge number of people, they are looking forward to getting their infections tested and treated. And behind all these numbers are a large group of people and families that we have committed, and as international community should live up to those commitments. Now, is there a delay in the slide? Okay, so it's important to note about the numbers that we always talk about, you know, and behind those numbers, as I say, are people. And we always have heard about 71 million people living with hepatitis C in Asia. And if you look at specifically Western Pacific, where one of our regional WHO offices belong to, and another one is the Southeast Asia region, we have a huge prevalence. We have one of the highest disease burdens in our regions globally. And if you look at really the mortality, hepatitis C still importantly holds a value there, and 30% of the viral hepatitis related death out of the 1.4 million globally were related to hepatitis C. Hepatitis B nowadays tend to really don't get the focus as to how we have been giving focus on hepatitis C. But I wanted to really reinforce the fact that there are 257 million people living with hepatitis B globally. And again, Western Pacific region or the Southeast Asia region in terms of prevalence is extremely high again. Now, if we look at the mortality of the viral hepatitis related deaths, 66%. Now, the earlier for hepatitis C was around 30%, but around 66% of the viral hepatitis related death are because of hepatitis B. And there will be, and there is a time when we cannot ignore hepatitis B anymore. And we have to really take this into account when we are designing our own viral hepatitis related responses. Now, death because of viral hepatitis is globally highest in the Western Pacific region. I think many of us know this, but this is for people who don't, who haven't followed this information. It is second in the Southeast Asia region, and the Western Pacific region accounts for approximately 33% of the global death, while Southeast Asia region accounts for approximately 30% of the global death. Now, I wanted to quickly show this with a very rough diagram that, as I said, we have done very well. We have started programs for hepatitis C, but we cannot continue to ignore hepatitis B. If you really look at this, both for sero and for repro, the burden of hepatitis B is also or is far greater than hepatitis C. I'm not saying that we should not focus on hepatitis C, but hepatitis B, we cannot continue to ignore it or don't do much as national programs when we know that cirrhosis or HCC related to hepatitis B is far more higher or a greater concern than hepatitis C. Hopefully we will also get a cure like how we have managed to get hepatitis C for hepatitis C. But that is not the case, but it is time that we start deploying potential mechanisms and solutions and look for opportunities as to how we can address hepatitis B. Now, global policies have always been done, and we have made these policies at the world's highest level for the last 11 years. Starting from 2010 till 2016, when we started speaking about elimination of viral hepatitis. The World Health Organization with the headquarters beginning and then coming up with updated guidelines. And the latest one was 2018 with the pan-genotypic regimen for hepatitis C to treat all. Today, we're going to hear more about updation of using antivirals for pregnant women for prevention of hepatitis B mother-to-child transmission. The regional offices that we have here, CERO and WIPRO, and also the country offices have been making their plans, supporting the governments, supporting the national programs and the country offices to make sure that we are responding to this. So with or without COVID-19, these policies has been made, these guidelines exist, and the technical expertise and the support of WHO regional offices along with the country offices exist. And we cannot ignore hepatitis, viral hepatitis, because we have a COVID situation which is throwing everything out of gear. We have to find opportunities, we have to find mechanisms to make sure, and those have already been cited in a way to strengthen the healthcare systems. Now again, we have much talked about prevention, and rightfully so. For hepatitis B, a lot of the focus has been on vaccination and preventing mother-to-child transmission. And that has been available since 1981. We also have talked about vaccination of key population or at-risk population. There has been divided opinions on when or whether or not adult population should be vaccinated, but we do have the vaccine. And if we want, this is an extremely cheap and effective vaccine, and it can be very well deployed. We have had hepatitis C related prevention efforts as a part of our global HIV or harm reduction programs, and that has been used or discussed in many ways as a part of prevention of hepatitis C related programs. We have had tenofovir for hepatitis B treatment, which is very widely used for HIV treatment globally, and this is no longer under patent. So if we want to put as many people on treatment for hepatitis B using tenofovir, it should not be an obstacle anymore. We have a global commitment to treat a number of people to bring us towards elimination. Where are we in terms of that? COVID-19, are we going to say that COVID-19 was there for 6 months to 1 year in 2020 and we could not treat that many people, that many number of people? Would that be something that we would say in case if we are not in a position to reach our targets? Entecavir, which is also recommended for the treatment of hepatitis B, we have this in multiple generic forms. Yes, there has been a bit of an issue in terms of getting syrups, which are recommended for pediatric or children, but both entecavir and tenofovir has been widely used and has been available for the treatment of hepatitis B. And it is almost registered in every country, I'm sure, for the treatment of HIV. And it would, in case if there are countries which have not approved tenofovir for hepatitis B related indication, it should not be a challenge to make that happen. And I'm sure the WHO officers, along with the Ministry of Health, provided the need is there, would be in a position to take that up with their FDAs very effectively. Pangenotypic DAAs have been available. And it is almost available across all the countries in WIPRO and also within CERO. And in some countries, if not at all, in all the countries, it costs less than $40 for a 12 weeks treatment. So both for prevention and also for treatment, we have had all the mechanisms and all the infrastructure or the medications or vaccines that are needed available already. In conclusion, political will and global commitment exist. So without COVID-19, these commitments exist. And by 2030 and in the middle 2021, we would be answerable to the global platform where we stand. We cannot say that COVID-19 was there and we were not able to achieve those commitments. Vaccines for prevention and medicines for treatment has been made accessible, and it is up to our governments and it's up to us to push for it to make sure that these are deployed in a way that we are moving towards the targets that has been set. Prices for these vaccines and medicines have been low and affordable, and it's for us to get multiple suppliers in our countries and to make sure that we get this. If not, we are getting it currently. It's for us to make sure that we're getting this at a price which is affordable for our programs. There are ways where national programs can reach out to or to utilize to ensure that there are multiple drugs or multiple vaccine suppliers for lower pricing. This has been done. Lastly, which is, I think, Dr. Joel also had touched slightly, is also that COVID-19 has substantially increased the testing capacities in many settings. And PCR platforms, including cartridge-based nucleic acid testing technology, has been reinforced for testing of COVID-19. COVID-19 is not going to be there throughout. And we can utilize this resources, so this testing capacity, to make sure that we are finding the kind of people that we need to achieve our elimination targets. We also are testing newer drugs, which we would know with RCT data sometime in September and October, to know whether these drugs actually work for COVID-19 treatment also. With that, thank you very much.
Thanks, Yutan.
Thanks, Yutan. And Margaret, do you want to take over, please?
Yeah, thanks. Thanks to all of our speakers. I'm really conscious that we're running behind time, and I realised that where I've sent a message in the chat about speakers only having a minute left, that you can't read it. So that's probably been a really unhelpful way to chair. It's just been apprised of it. Joe, you had one question where you've got 10 seconds to answer it if you can see it. Which is really to do with the Q&A of what type of test do you think could be done at home? I'm just really conscious though, if we could, can you answer that just in 10 seconds?
I've answered it in the chat, Margaret.
Oh, thank you. Good, then we will move on to our second session. Could I ask all of these speakers, I know you had 8 minutes, but I'm gonna ask you, because I really want to have the opportunity for us to have the panel session at the end, to really work to reduce your presentations to 6 to 7 minutes. With that in mind, I'm going to introduce Pauline Chan, who is Senior, actually I don't even know your formal title, at WHO Western Pacific Region Manila. She's the boss. I'm going to put it like that, to provide a brief overview of what's happening. Pauline.
Thanks, Margaret, but I'm not the boss, but I am the Regional Hepatitis Lead. Thank you very much. So I'm going to share my screen. So does this work well? Okay. Yes. Shall we chug along? Thank you very much. So today I'm going to tell you a little bit about the new guidelines from WHO, which is being launched on Tuesday. And this is happening amidst the COVID global pandemic. So just a little flashback. In 2016, all countries endorsed the call for action. That is, elimination of viral hepatitis as a major public health threat by 2030. Now, what elimination means is that by 2030, we should, as the whole world, reach new infections of less than 0.1% among children 5 years of age, and also a 65% reduction in death. Now, there are 5 core interventions covering vaccination, prevention of mother-to-child transmission, blood safety and injection safety, harm reduction, and of course, testing and treatment, which if delivered at very high coverage, it will get us to elimination. A flashback also into what the burden is, and I won't go through too much because it has been eloquently pointed out by Gitten and the others. But vaccine has had tremendous impact on reducing new infections in children. In the top slides of the map, you can see before 2000, we had a prevalence of almost 5%. And with the impact of immunization worldwide, this has brought down prevalence of hepatitis B in children to less than 1%. But we have more to do. The goalpost by 2030 is to make it less than 0.1%. And of course, the substantial burden of having chronic infections in adults. WHO testing and treatment guidelines have spanned many years now. We have immunization guidelines for decades, and the most recent update has been in 2017, where all infants should receive their first dose of hepatitis B vaccine as soon as possible after birth, and preferably within 24 hours. And then the birth dose should be followed by 2 or 3 doses to complete the primary series. And in 2015, WHO released the first treatment guidelines on who to treat, and these guidelines haven't actually changed. It calls for use of tenofovir and entecavir. And in pregnant women, however, because of the lack of evidence and studies, there was no recommendation made on the routine use of antiviral treatment to prevent mother-to-child transmission. But any hepatitis B infected pregnant women should be treated the same as for other adults, and tenofovir is recommended. And in 2019, consolidation of testing in pregnant women recommends for integrated testing, universal testing during antenatal care for HIV, syphilis, and for hepatitis B and C testing according to prevalence settings. So today we are going to talk about the new guidelines on the antiviral drugs for pregnancy, for prevention of mother-to-child transmission. And one of the main reasons to reconsider these PMTCT recommendations is because the evidence has been generated by studies, by trials, and by programs implementing in countries. There have been requests also from regions and countries in the context of triple elimination of HIV, syphilis, and hepatitis B, mother-to-child transmission. And there are some concerns that timely birth dose may not be sufficient to reach the goalpost of 2030. There's a lot of discussions, how do we further prevent mother-to-child transmission, especially for infants born to hepatitis B infected pregnant women. We call them the hepatitis B exposed infants, HBV exposed infants. So in the last several years, what we do know is that the foundation of hepatitis B prevention really is like a pyramid. It's based on a foundation of vaccination at the bottom, a strong system to test and link to care for mothers and their child. Immunoglobulin is used in many high-income countries, but there are supply issues in many middle and low-income countries. But we also know increasing evidence that antiviral treatment can make a difference for the subsets of women with high viral load. So on Tuesday next week, WHO will launch the new guidelines on prevention of mother-to-child transmission and the use of antiviral prophylaxis. Very quickly, it says that women who have a high maternal viral load should receive tenofovir prophylaxis from 28 weeks of pregnancy until at least birth. Then, of course, there should be vaccination, including the timely birth dose for the child. And in settings where hepatitis B viral DNA testing, viral load is not available, then the hepatitis B E antigen testing can be used as an alternative. These are the top two recommendations. And of course, we know today we are in the midst of a major wide-ranging pandemic that has really impacted hepatitis programs globally and essential services. More than 15 million have been infected. But I do think, like the others, that although there are major challenges, there are opportunities to build back better. I'm not going to go through the challenges because it's been so well said by the others. But what we do realize that as society, as human beings, we now understand that health is a public good and health is truly important for social and economic development. And UHC is now more important than ever. On the right-hand side, WHO has provided operational guidelines for essential services that you can look into. And it really is about trying to talk about decentralizing, piggybacking on innovations in delivery, and making sure that when you reorganize services, you think about the best way to deliver for people who have chronic conditions as well. In summary, amidst this world affected by COVID-19, elimination of hepatitis new infections among children remains critical. we have our future to get into. And these new recommendations will provide opportunities for better cross-program efficiencies and integration. And whatever it is, we need to coordinate and joint manage the people to make sure that we can get to a hepatitis B free generation of the young. These will include immunization, maternal child, and of course, all of us in the fraternity of hepatitis and the others. Thank you very much.
Thanks,
Over
Pauline.
to you, Margaret.
Thanks, Pauline, and thanks for keeping to time. Sin, I can't do, and you did keep to time, thank you. For the panelists, that means I need you to finish in a minute. So that I think will work out better. Our next speaker, and again, if I would just request people to try and reduce your presentations to 6 to 7 minutes at most, is Sayeda Zahira from Pakistan, who's going to talk about the impact of hepatitis care, sorry, COVID-19, impact of hepatitis care in Pakistan. Sayeda, welcome, and thank you.
Zahida, you're on.
You there, Sayeda? Okay, we might go to our next person then. If you're not there, Sayeda?
Yes.
Okay, thank you. Could you?
Hello.
Yes, we can hear you. You want to share your slides, Zahida?
Yeah. Now I'm just
Tommy, are you able to help Sayeda?
Margaret, yes, but it's about her bandwidth in here.
Sayeda, at the moment your connection is really poor. I might move to the next speaker, and if you could just have a look at that connection,
Okay.
please. And then we'll come back to you. But at the moment, I don't think we can really hear you at the moment or see the slides. So we'll come back to you at the end of the session. We're just going to move straight on to the next speaker, Warenja Wara Renatu from Indonesia, to present, please. Leandra, we're having difficulty as well. Do you want to just check your we can see your slides, but we can't really hear you. Just check your microphone. Okay. Again, we're having problems with the microphone there. We might, again, if you guys could just do some home testing on the microphones, and we'll go on to our next speaker, because I know we could, Zinning from China, and we see whether we can hear you, Zinning.
Yes, could you hear me?
Yep, and Tommy, can you go to the right slides, please?
Yes, could you run my slides, please? So good morning or good afternoon, everybody. It's really my pleasure and the honor to have a few minutes to share some of the experience in Wuhan city as a representative for China. So my title is Care of Patients with Liver Disease During the COVID-19 Pandemic in China. I'm Dr. Chen Lim from Wuhan. So next, please. Next slide, please. Next slide, please. Yeah, as you may not know that actually I'm a hepatologist, but the setting in China is the hepatologist is within the Department of Infectious Disease. No, not that far. Please go back to the second slide. Please go back to the second slide, please. So during the pandemic of COVID-19, yeah, we are infectious disease doctor, but also we are hepatologist. So we took care of the patients for the COVID-19, but we also did not forget our liver disease patients. So during that time, actually we were, as you know, that we were in the center of the pandemic in China, and not just for the clinical practice of ourselves, we also were responsible for set up the quick diagnosis guidance for the provinces outside of Wuhan. So next one, please. Actually here, the picture showing me and my assistants will interact with one of our patients. So we actually quickly assembled a guidance for the quick diagnosis and treatment for COVID-19. And during that time, we were also very, very care about the patients with liver disease, and also we care about how this COVID-19 will affect the liver. So we analyzed one of the cohort retrospectively about the clinical characteristics and the risk factors of liver injury in COVID-19, which was published in Hepatology International. A few other publications were in Journal of Clinical Investigation and the British Medical Journal that showing the clinical and immunological features in severe and moderate forms of COVID-19 patients. So next, please. Next slide, please. Can I run the slides? Yeah. So the reality is between January 23rd and earlier April, this is the time that this whole city was locked down. And the liver patients who could not come to our clinic, and we have managed several ways to deal with this situation. So that's what I like to share with you, and which could be different in some of the countries who has many COVID-19 patients now. So next, please. Next, please. So in fact, right after the lockdown of the city on February 14, our hospital launched a program that is the Tongji APP program for patients with a video one-step series of online consulting, and also we can make diagnosis and even send the medicines. So this provided a kind service to our patients, and and also importantly is in this way we avoid cross infections during the epidemic time. Next, please. Next, please. So there is a kind of delay of the slides.
Is that the right slide, Ding?
So many of the liver patients, the treatment was not timely or interrupted with the liver disease patients. So discontinuation of antiviral drugs in patients with CHB leads to hepatitis flare and even liver failure. And now these patients come to the hospital once the city is reopened. So in the clinic, now we have seen many of these patients now hospitalized in our hospital due to their discontinuation of antiviral therapy. Next, please. Next, please. So at the recovery of the earlier phase, the reopening of the general liver disease clinic, all our doctors actually was still working in a full protective state, like biosafety level 3. So the liver disease ward is also divided into general wards and observational wards. Patients with liver disease were first admitted to the observation ward. And during their stay in the observation ward, we will test their COVID-19 virus antibodies as well as their lung chest, as the chest CT. Once we confirm there is no infection of COVID-19, then these patients can be transferred to the general ward. So this takes like 2 steps for the patients to get into the general ward. Next, please. So in this way, we will assume there is no congenital infections of the COVID-19 in our liver disease patients. So there are several ways that we deal with our daily clinical practice. For those patients with chronic liver disease, including the compensated cirrhosis, we have a good personal protection to prevent COVID-19 infection, and the visits to specialized postponed. Routine laboratory tests can be performed locally or off-site. And certainly we use telemedicine visits by phone or video interviews wherever that is possible. For those patients with decompensated liver disease, including HCC, of course, certainly we need to have a good personal protection to have our patients protect COVID-19 infection. And this care can be maintained according to some guidelines, international guidelines, as well as our local guidelines. And we ask them to minimal expose to medical staffs because our doctors also seeing COVID-19 patients by using telemedicine visits by phone or video interviews. And the list for those transplantations should be restricted to the patients with poor short-term period. Short-term the progress. Guidelines on prophylaxis of spontaneous bacterial peritonitis and hepatic encephalopathies should be closely followed and monitored. And we also including testing for SARS-CoV-2 in patients with acute decompensation or acute on chronic liver failure patients. Okay, next please.
And 1 minute, please, Zing.
1 minute? Yeah, this is my last slide.
Thanks.
So for those with HCC, I think care should be maintained with according to the guidelines, and also minimal exposure to the medical staffs. And in case of COVID-19, earlier the admission, of course, for those should be recommended. And for those who needs to do the liver transplant, for those who after transplant patients, maintain care according to the guidelines and minimal exposure to the medical staffs using telemedicine or with
Okay, Zin, is it just me or is anybody? I think she might have gone.
We can't hear her.
Oh, you can't hear me?
Yeah, we can hear you now.
Yep, quickly. Yep.
Okay, yeah. So this is my last slide. So I just like to share with you for different kind of liver disease patients, we have managed it a slightly different way, but mainly we will using telemedicine. And now since the city has been reopened and also everything gradually returned to normal, so there's no problem now. I think there was a delay for diagnosis and treatment during the pandemic, but everything is getting to normal. So with that, I thank you very much for your kind attention.
Thanks very much, Jen, and thank you for pushing through with some of those technical difficulties. I understand that things are right again with Saida. So do you want to try again, Saida? Thank you. Also, just while Saida's getting her slides up, we're really conscious that we're running later than we would like, but we really do want to have the panel session as well. So we will extend the symposium to ensure that happens. But Saida, over to you, please.
Zaida, I've got your slides up. I've got your slides up, so you can speak to them. Okay.
Okay. So thank you very much. Good morning.
Not working this end. I'm sorry.
Saida, unfortunately, we're not able to hear you. I think what we're going to do is we'll go to the next speaker and then we'll try again. But if nothing else, we'll post your slides. But unfortunately, we can't hear you at all, which is really disappointing. We'll come back to you one more time after the next speaker and see whether we can try again. So we'll try again with now Wirendra. Do you want to have another try?
Yeah, yes.
Okay, fire away, Wirendra. We'll see how we go. Welcome. Sorry about this. And if we can just do it.
Okay, thank you. Yeah, thank you, Margaret. I will presentation hepatitis B and C services in Indonesia amidst the COVID-19 pandemic. Indonesia consists of 34 provinces and 514 districts and more than 17 islands. Its BSI antigen prevalence in Indonesia 7.1, estimate 17 million people hepatitis B infected. And anti-HCV prevalence in Indonesia 1.1, estimate 2 million people infected by hepatitis C. The hepatitis program became the program in Ministry of Health in 2015. And in 2019, hepatitis program has become the national priority program along with tuberculosis and HIV program. Next. Hepatitis at the national level through the Ministry of Health, the government commit to the prevent and control hepatitis B by increasing access for hepatitis testing and treatment. The Ministry of Health is committed to prevent and control hepatitis virus by increasing access for hepatitis testing and treatment, especially for pregnant women. Ministry of Health regulation number 58 endorsed in 2015, and the regulation number 55 endorsed in 2015. And then the Ministry of Health regulation number 77 endorsed in 27 about infection prevention and control, health facility, and Minister of Health regulation number 15.2 endorsed in 2017, elimination mother-to-child transmission for HIV, syphilis, and hepatitis B, known as triple elimination. Hepatitis B and C situation. The district or city conducting early detection of hepatitis B. Every year, the number of districts which conduct early detection of hepatitis B, in the further will call early detection hepatitis B, always can achieve the indicator target in 2022, January to July, percentage of district or city conducting early detection hepatitis B, 73.2%. It means not achieve the indicator target target yet, but optimism can be achieved until the end year. Hospitals which are capable the direct acting antiviral is available in 15 provinces, 37 hospital we have target in 2024. All provinces are capable taking DAA treatment. Next, achievement on early detection of hepatitis B among pregnant women. Since 2015 to 2020, the number of pregnant women who are tested HBsA antigen always increase in every year. In 2015, we start with only 32 974 pregnant women screened for hepatitis B. In 2019, we screened 2,576 and 918 pregnant women, or 15% the estimation. Efforts of increasing the pregnant women who are tested HBsA antigen in 2015 to 2019, 60%. Average of pregnant women who were HBs antigen reactive in 2015 to 2019, 2%. From this map, you can see the distribution of HB antigen reactive in Indonesia. Next, from 27 to 2020, there are 5,361 hepatitis C patients received the DAA treatment. Out of 561 patients, or 37.4% were serosic patients, and 27% had co-infection with HIV. The highest risk factor based on DAA treatment were people with injecting drug user, 51%, followed by hepatitis 25%. Next, hepatitis B and C situation during the pandemic. The hepatitis B screening in pregnant women, comparing the same period of January to June 2019 to January-June 2020, the number of pregnant women screened for hepatitis B decreased by 41% in 2020. In 2020, the number of pregnant women screened for hepatitis B March to April 2020 decreased by 41% compared to February 2020. The number of pregnant women screened for hepatitis B in May-June 2020 decreased by 72% compared to March-April 2020. Next, yeah. Anti-HCV screening in high-risk population. Comparing the same period of June 2019 to January-June 2020, the high-risk population screen for anti-HCV decreased by 60% in 2020. In 2020, the high-risk population screen for anti-HCV in March-April 2020 decreased by 53% compared to January-February 2020. The high-risk population screen for anti-HCV HCV in May-June 2020 decreased by 6 compared to March-April 2020. Next slide. The hepatitis B and C services challenge during COVID-19 pandemic. Hepatitis B and C challenge during COVID-19 pandemic patient afraid of going to the healthcare services due to COVID-19 infection. Postpone the routine checkup, seek for self-medication. In health services, limitation of health services hours, inadequate personal protective equipment. Some of inpatient wards are switched for COVID-19 ward. And then hepatitis program officer, the officer are assigned for COVID-19 and logistic distribution. Minister of Health respond to hepatitis services during COVID-19 pandemic. The first COVID case was in March 2, 2020. Up until July 33, the 2020, 93,657 COVID-19 cases in Indonesia. There were impact in other healthcare services, including hepatitis B and C services. Ministry of Health responded by issue circulation letter on hepatitis services during COVID-19 pandemic and adaptation in the new era. The circulation letters provide guideline to maintain the hepatitis during pandemic and some adaptation for hepatitis B, vaccine and hepatitis immunoglobulin provision for infants that were born from COVID-19 and hepatitis B infected to mother. Way forward, actively using webinar and online platform to increase the capacity hepatitis healthcare personnel for all 34 provinces, actively doing the monitoring and evaluation in the hepatitis program through online and platform to give information, overcome challenge and discussion. Develop guideline in hepatitis B and C services in new normal era. And World Hepatitis Day webinar with adaptation have future them to generasi bebas hepatitis on July 28, 2020, advocacy and to increase awareness on hepatitis. Please join our World Hepatitis Day webinar on July 28, 2020 on the right our World Hepatitis Day Tribune for social media, Instagram, Twitter, and WhatsApp.
Thanks, Dr. Wendra. Sayed, I'll hand it over to the next two speakers.
Yeah.
Okay, I think we'll go with Hang Dao first from Vietnam. Zaida is still trying to sort out her connections, changing her laptops and so on. If Hang Dao is there,
it's me.
oh,
Yes, it's me. Yeah.
Please go ahead, Hang Dao.
Yeah. So it's my pleasure to present about the COVID-19 impact on hepatitis care in Vietnam. Can you see my screen now?
Yes.
Yes. So the lecture will divide it into three parts about the viral hepatitis condition, the COVID-19 situation, and how we manage the viral hepatitis patient in the pandemic. So about the viral hepatitis condition in Vietnam, it still ranks the third in the top 10 causes of mortality, with the seroprevalence of HBV range from 7 to 19%, and the seroprevalence of anti-HCV range from 1 to 3.3%. However, we are expect about a decrease in both HCV and HBV in 2030. According to the current data, we are still suffering from the complications of chronic hepatitis, including the decompensated liver cirrhosis, compensating liver cirrhosis, and SCC is now the first rank of mortality in malignancy in Vietnam. The role of the MOH, Ministry of Health, is very important in releasing the updated guideline for HBV, HCV, SCC, and they also have a lot in promoting the educational activities, especially in the primary care levels. They also have a lot in the insurance coverage for the antiviral drugs, setting the viral hepatitis units, and now we are having two projects, the national projects regarding the viral hepatitis elimination and to prevent the mother-to-child transmission disease, including HBV. So this is a quick survey we have performed with our colleagues, working with the chronic hepatitis, the viral hepatitis, and we found out that our patients have been treated both by the GP and by the specialists in different fields, hepatology, GI, or infectious disease. So how about the situation of COVID-19 in Vietnam? This is the data until July 20th, and we have 383 cases, and now it is 412, and we have 23 cases, and the first cases is on January 23rd. And what about the strategies carried out? The government has released in total 16 documents, mainly on the guideline on how to respond promptly with this condition. And for the Ministry of Health, we have released 45 documents, and mainly on the documents regarding to the medical documents. The four main strategies that the Ministry of Health carried out to the society includes, the first one is to strict control on the passengers and returners from the outside. The second point is to increase the surveillance in the communities. The third one is to enhance the communication for the communities, and the fourth one is focus on the quality of the treatment. This is the timeline to illustrate the response to each wave of COVID-19 in Vietnam, and as you could see, we have 3 weeks of social distancing at the end of March. And this is the analysis of the characteristic of the COVID-19 patients in Vietnam, and you could see here that more than 75% of the patients have no symptoms. It means that our quarantine and detection process is really good. And what we recognize in the early phase of the pandemic, we recognize that we have to face with the risk of cross-infection in the hospital. We also have to face with the shortage of the medical equipment, the health personnel, and we also recognize the risk of increasing burden in other diseases due to the reduction of our patients visiting to the hospitals. So what have we responded? So we use the health declaration, both offline as the traditional documents and the online, such as apps, and we promote more involvement from the IT, apps, websites, to provide the clarified information and instructions for all the people. And inside the hospital, we promote the virtual activities such as the telehealth. This is the picture that how the Ministry of Health and other hospitals join in the telehealth to consult for the severe COVID-19 cases. And the second part is that we classify the different levels of the healthcare units to restrict the transfer, to enhance more screening, and to restrict the invasive procedures with high risk. And coming back to one survey we have performed to ask our colleagues who treat the chronic hepatitis, viral hepatitis this time. So we found out that nearly 90% of our colleagues reported that they found the number of chronic hepatitis B patients decreased during this time. And when asking what about the reasons why the patients could not go to the regular follow-up, we found out that the most predominant one is that the patients are afraid of the pandemic spread. And the second thing is that the geographic related difficulties such as the limited transportation or the quarantine. So how about after the first wave, how about the change of the number of patients after the second wave? We saw that comparing to the previous data last year, 50% of the colleagues reported that there was no difference, but 1/3 of the colleagues reported that they still saw the lower number of the patients comparing to last year. And what the healthcare centers have responded with this change to manage the patients better. This is the picture from this is a picture from a liver unit in a hospital, and you could see that the patient go back to a follow-up, and they wear masks, and they still remain the 2 meters distant. So we also promote the online or the phone consultation to detect the early complications, as well as to check the treatment compliance of the patients. And the insurance staff has performed very good things, that they have extended the prescription duration from 1 month to 2 months. So it will be very helpful to reduce the traveling of the patients. And we'll also try to foster the activities of the local healthcare units. So after all of these strategies, we also have asked our colleagues, what do you think will be the effective methods in this time? And many of our colleagues have suggested different methods. For example, building up the mobile apps, or using YouTube channels, videos, or using online support via the hospital website, or using the hospital hotline support. So I would like to conclude my presentation in several points. The first one is that viral hepatitis is still a burden in Vietnam due to the high prevalence as well as the high complication rate. The COVID-19, even though that we have the initial success in management, but we are waiting to complicating progression in the near future when we reopen. And for the viral hepatitis management in the pandemic, there is no available data on the impact for the patients, hospitals, and society in our country. But as reported, we saw the decreased number of the patient follow-up, and we hope that it is increasing on the trend of the new norm. And we also found out that the application of the IT advancement will help a lot to enhance the patient management. I would like to thank you all and acknowledge all of my colleagues and hospitals attending in the survey to evaluate the impact of COVID-19 on viral hepatitis management in Vietnam. Thank you.
Thank you, Heng Dao, and thank you for sticking your time. I didn't have to show you the 1 minute warning, so that's good. Now, coming back to can you unshare your slides, please? Yes, thank you. So coming back to the last presentation, which is Zahida's, unfortunately, she's unable to disconnect. She's allowed me to quickly go through these slides. If you will just bear with me for just a couple of seconds. I wanted to present this because Punjab is the largest program in Pakistan for the hepatitis control, for hepatitis C currently at the moment. So, and that has been the biggest hit. This slide just shows where we are with our COVID business. Can you hear me all right? And can you see this screen, Margaret?
Yes,
hello?
we can, Saeed. It's good. Thanks.
Okay,
yeah.
good. So this is the COVID situation that has happened. It is on the decline at the moment, we think, but there may be a second wave that is going to follow very quickly, particularly after our upcoming Eid holidays. So we're all waiting with bated breaths to see what happens. This is the situation with the Punjab program. A recent resurvey suggests that Punjab is now about 8.9% prevalence for hepatitis C, whereas previously we were putting it at 5%. And at the bottom of the screen, you can see that they have really done a remarkable job in screening, in detecting PCR and initiating treatment. So something like 271,000 people may have already been started, and a very high, reasonably high cure rate of 89%. Of course, the program has been hit very hard, and this is the key slide, I think. It's a little crowded, but we can go through this quickly. So pre-lockdown, so our COVID, first case of COVID was sometime in February. On the 9th of March, the country went to a lockdown till the 22nd of March, which was, on the 23rd of March, it went into a lockdown till the 5th of April, and that lockdown got extended and so on and so forth. So pre-lockdown registrations, 17,524. They go down immediately to 3,230 and then start to come back up as the lockdown is eased. And it has never gone down up to that level. We are still, the latest figures that they're showing is roughly 1/3 of registrations in their program before the lockdown started. And this goes all across. I am extremely impressed that they were still able to enroll HCV patients, 1,207 HCV patients, compared to a little over 3,500 before the lockdown. So there has been a major impact on all these services. This is just a schematic of the things that we've been talking about. And so I'll just skip this slide. What have they done? So there was issuance of guidance for clinics to work under COVID situation for disbursement of the full course of treatment to the patients who were already on treatment or diagnosed PCR positive. So they did not stop. They were able not to disrupt the treatment of patients that had already started, and they were able to start patients on treatment who had already been worked up completely. Arrangements were made for home delivery of medicines involving courier companies. 5 teams of provincial monitors constituted to oversee the performance of the hepatitis clinics. There were online WHO courses, certification courses on infection and control of COVID-19 that were developed, and almost all of the medical officers got through this certificate course. Guidelines on infection prevention and control, hospital-based management, use of PPEs were also developed, and virtual capacity building sessions were held. So currently they're working on the concept of telehealth, teleliver, having following main objectives: health, hepatitis awareness of the general public, consultation sessions with patients, and virtual capacity building of relevant healthcare providers, including the medical officers and the paramedical staff. So they really have had quite an impact. And they're, moreover, initially their hepatitis PCR labs got taken over by the COVID testing, but since then the number of labs have certainly increased many-fold, 3- or 4-fold across the country, and that has strengthened the existing lab system. And the hope is that once the COVID issue dies down or goes below a certain level, this excess capacity will start to test for hepatitis B and C in these labs. So there is always a silver lining in whatever situation there is. So just very quickly to tell you that there has been a major impact on our biggest program, which is the Punjab program, and let's see how they recover. Thank you very much.
Thanks, Saeed, for doing that. Much appreciated. We're going to go straight on to the panel session. We're going to spend 15 minutes, and thank you, and my apologies to people who've stayed on the line, and my apologies for running over time. It's always slightly difficult with the technical issues. If the panel members can be brought up so that we can see who you are, please, that would be great. There's a series of questions that have been put through the Q&A and also that people have sent to me, and what in the sort of, we had these questions up for discussion, having listened to the presentations and also seen some of the questions that have come through the Q&A and that were sent beforehand. The question I'm going to ask you as the panel members, as I sort of reflected on what's going on, is COVID-19 is obviously impacting on the viral hepatitis elimination response. And the two things that I think people are asking is, what do you think is the most effective thing to stop the extent of the derailment? And so what can we effectively do to get things started? And in part with that, what can we take from COVID? So one of the questions we got sent beforehand was the fact that there's now testing, so that there's molecular testing available in some countries now that was never before. Can this be, how can we exploit this for future use? So my questions to you are thinking about what do you think would be some key things, and just 1 or 2 key things from each of you as to what we need to be doing to reduce the likelihood of or any greater effect of derailment, and how can we exploit what the benefits of or some good things from COVID into the future. And another key question we've got after the Q&A is, in the background, that enormous amount of money suddenly becomes available in countries for COVID. Why can't that be translated into or used in the future for elimination? So they're the questions for each of the panelists. I'm going to start with you, Kerry, because you haven't spoken, so I'm going to start with you. as a panelist.
Great, thank you. Thanks, Margaret. And thanks for the opportunity to be here today. I think there's so many things that can be learned from the current situation that we're in. I mean, I think we did a survey of our members very recently, and a lot of the messages that came through from previous presentations have also come through here. And one of them is really about this fear of accessing healthcare facilities being a major barrier for people testing and for people accessing treatment. And it's this fear of this fear that's going to persist as we go on, right? And we know that, you know, community-based organizations are very good at providing services that people are comfortable with and that kind of alleviate that fear. But, you know, research that's been done by UHC 2030 around the COVID response has shown that very few countries are using their community organizations in this fight against COVID. And since the communities disproportionately affected by COVID are also in many cases the ones disproportionately affected by viral hepatitis, you know, there is a real opportunity here, not just to fight COVID more effectively, but to also advance the cause of hepatitis elimination within this pandemic. And I think, you know, the skills that we use every day as community organizations to fight hepatitis around vaccination and screening and outreach and community-based care are exactly the skills that are going to be needed as we progress through the COVID pandemic. So I think there is a real opportunity there. So I think it's really up to community organizations to advocate for their inclusion in these programs, and for governments to really recognize the power that civil society has in both responses. Thank you.
Thanks, Kerry. Burnet, your thoughts on this, please, if you haven't had an opportunity to speak yet.
Sorry, me?
No, Burnet.
Yeah, I agree with the observations from Kerry James that the involvement of community has been minimal in this response. And we have seen how the testing both for hepatitis B, C and access to medicines is reduced by 40 to 60% in many countries across the globe. But we have a silver lining here also, that during the COVID attack, we learned how the HIV response basically was scaled up to reach PLHIV in terms of multi-month dispensing, community dispensation, and other opportunities that were utilized. Also, COVID-19 taught us the response, basically how the testing can be rapidly expanded given all the challenges, even to decentralize to the farthest level and also the fast track approvals. So we need to utilize these learnings both from the expansion of the services is possible and involvement of community can be done. But we need to utilize these learnings into our hepatitis response so that we don't falter and don't lag behind our targets. Over.
Thanks, Burnet. Jack.
What an interesting kind of question. I mean, for me, there's several issues. One of it is that within the community now, there is an increased level of awareness of infectious diseases. And that hasn't happened before. And it's a really good opportunity so that, you know, our political masters do understand that infectious diseases have an impact. The community as a whole now understand that infectious diseases have an impact. There's a whole range of lessons though that we could learn in responding to COVID that we have learned with HIV, hepatitis B and hepatitis C. One of it is that, you know, that COVID has a social impact and that we need to be aware of it and respond to that. I was kind of really aware a couple of weeks ago when a news reporter on the Australian Multicultural channel said, they said several weeks ago when transmission started to increase, that the increase was occurring because people were doing the wrong thing. Now that changed the dynamic of COVID being needing a community-wide response to developing up a level of stigma that we hadn't seen before. And I think we need to be really aware of the fact that stigma is developing. We have political kind of people across the world calling it the China virus, and those kind of really ugly, racist kind of things, which do affect people's access community services. The stigma I get really worried about because it will impact on the people's willingness to get tested in the first place. And we need to actually start addressing that level of stigma at a community-wide basis and start using language that's accurate. So, the increased levels of awareness of infectious diseases, the fact that there is money to be found. Governments have gone into huge amounts of debt for this infectious, for COVID, and rightly so. But that also means that they can't have the excuse that there's not money to respond to viral hepatitis as well. I'll leave it at that.
Thanks, Jack. I'm going to go Pauline, Rose, and Cieda if we can get Sarah on the line. So Pauline, any thoughts on 1 or 2 minutes on the best way forward to exploit the opportunity, or just your thoughts, please.
Well, I think the realization that it is really critical and important to test. So I don't know whether people realize is that, the age group that is really at risk of severe COVID disease, which is more the older ones, and of course those with underlying undetected medical conditions such as diabetes, hypertension, but also probably including hepatitis, they're all in a more or less the same age group. While in public health programming, we focus a lot on vulnerable groups, the majority of the epidemic, particularly for hepatitis B and C, resides in the older age group because they were born before the era of vaccination, or they had the cumulative lifetime risk of being exposed to unscreened bird products in the old days, or unsafe medical injections in previously. So people should really be thinking about screening in a way any chronic conditions such as diabetes, hypertension, hepatitis, at least in Asia and the Pacific, as an integrated way of getting things done. And this may actually help them to go further on prevention of further risk, especially for COVID risk. So I do agree with Jack and all on the need for treatment literacy. Now more than ever, we are so aware of our individual health and how it impacts the others. So this is really a right opportunity to really push forward with health and treatment literacy in all communities. Thank you.
Thanks, Pauline. Rose?
You're on mute, Rose. Yeah. Okay, great. So thank you very much for the opportunity. And I think we should look at the positive side of things. And the positive side of things include the way that COVID-19 have accelerated the digital transformation. So basically here, when we talked about wanting to create awareness and all that, people are now using technology, so we can engage community a lot more using technology. And I think this is one of the things that should be focused, because we saw also the unprecedented solidarity during COVID-19, even amongst the community level. So get a lot more community volunteers, let them be agents of change and trying to create awareness, and not just amongst doctors, because people don't sometimes pay attention to us doctors anymore, but they do pay attention now to the fact that, there will be other diseases that can lead to increased death due to COVID-19. Use the opportunity to actually highlight which are the people that you really want to focus on. Yeah.
Thanks, Rose. Cieda, I'm not sure whether you're back online or not. Can you see?
Don't think she is.
Doesn't appear to be. Look, I know we're running late, so I'm going to sort of summarize the panel's comments on that, just because I'm conscious of the time that we're so well over, and then Sayed, I'll hand it to you. My take from the presentations that we heard today, and I thought they were fabulous, and thank everybody for those, is that COVID-19 is impacting at the moment on our viral hepatitis response, and this is a real concern. But we can just either spend our time being concerned, or we can say, what are the opportunities that this presents to us? We need to think of ways forward, and it's been really highlighted in the presentations in the panel discussion. That number one of our strengths in our area is community engagement, and that's what's required in COVID-19 as well. And we need to use our strengths to get engaged with that, but then also to take it back the other way as well. And as Rose just said, the community's been engaged. Let's get them engaged in viral hepatitis B or C, depending on your country and your needs. So there's an opportunity there. And thinking about it through the use of technologies in health services, and they could be simplified. Suddenly things that couldn't be done before, like giving takeaway OST doses, like Burnet said, suddenly become available. Opportunities become available. Diagnostic testing that was never allegedly able to be done before in certain circumstances to be rolled out to the same extent can suddenly be rolled out, and there's the capacity of health systems to actually do it. Surveillance systems have been strengthened in a way that hasn't happened before in a number of countries. We can suddenly do it, and let's exploit that. So there's lots of opportunities for us to exploit it, what's going forward with it. So they're the kind of things that, to me, I'm getting sort of a sense of feedback from the presentations and the panelists, that yes, there's concern, but there's enormous opportunities in all of the countries in the region to sort of really look at what we can learn from the COVID response and take it to the hepatitis response, but also be really mindful that the hepatitis response has some really fabulous things that it's done over the years, particularly in that community engagement, that we can take to the COVID response as well. So I think it can work both ways, and we should all be looking for those opportunities and trying to share information with each other to make sure that happens. So they're my thoughts as a quick wrap up of what I've heard today, and it makes me really kind of quite excited and optimistic about what we can do, and that we shouldn't be fearful that things will fall off the radar, and that we can really push our governments to be responding to health more broadly because of the increased literacy around infectious diseases. So they're my thoughts, but over to you, Saeed, to wind up.
Thank you, Margaret. So just a couple of points to add to what you've said. So two things have happened to my mind, or one has happened and one should happen. The first one that has happened is that the pandemic has laid bare the poor state of the health systems in many, many countries, particularly the low middle income countries. And that is causing a lot of shame, or should cause a lot of shame, to the decision makers. And I hope that this is an impetus to improve the overall health structure, which will of course benefit the hepatitis B and C elimination efforts. So I think that's one message that I think we have to shout out very, very clearly. Things have been exposed like they have never been before. And this is an opportunity to cash in on that. Secondly, I think we need to repurpose our message. So let me give you an example. In Pakistan, we estimate that nearly 340 people die of viral hepatitis every day. Now, with due deference to people who've lost their lives to COVID, what is the maximum death rate that we've had? 200. It is currently running at about 50. So we are talking about a different magnitude. And this is something that we have to convey to people. And secondly, look at Vietnam. They've lost nobody. And they, I'm sure, are losing a large number of people even as we speak due to hepatitis B with 19% prevalence and so on. And one can imagine what the liver cancer situation might be. So I think, for one, we need to put these governments to shame even more, to do something about their health systems. And secondly, we need to repurpose our message. We don't want to sound antagonistic, and we are very differential, of course, and we are very hurt with all the people who've died in many countries due to COVID, but there are many more dying due to viral hepatitis right now. So with those words, I would probably close the session. We are already running late. Thank you very much. This has been a joint effort between CEVHAP and the Burnet Institute with great support and help from the WHO. So very nice to hear from Poland about the new initiatives on the mother-to-child transmission, which are going to be extremely important, I think, and therefore we hope that this will carry forward. Once again, thank you to all the panelists. Thank you to all the participants. We had, at our peak, I think we had about 130 participants in the session. So that was a great number. And as always, thank you to Jenny and Vicky and the people at Burnet to help out with all the logistics and everything. Thank you very much.
And many thanks to our wonderful co-chairs. You did an amazing job. I know it was a very big program. And thank you, panelists, speakers, everyone, and also our attendees. Thank you all.